If you lose it, you'll have a backup. Okay, and don't forget to follow us on Instagram, Snow Convocations, so you have updates of who's coming to speak and you don't miss it. Now, please remember to silence your phones. As a reminder, next week we have multimedia artist Judy Gellis coming. She'll be talking about her fourth grade project. Today we're going to start out, before we hear from our presenter, with a musical number by McKenna Lenhart, who recently won the first place at the National Association of Teachers of Singing. McKenna will be performing The Boy Next Door from Meet Me in St. Louis, and she'll be accompanied by Elijah Hancock. Please welcome McKenna and Elijah.
Doesn't try to please me, doesn't even tease me, and he never sees me glance his way. And though I'm heart sore, the boy next door, affection for me won't display. I just adore him, and I can't ignore him, the boy next door. How can I ignore the boy next door? I love him more than I can say. Doesn't try to please me, doesn't even tease me, and he never sees me glance his way. And though I'm heart sore, the boy next door, affection for me won't display. I just adore him, and I can't ignore him, the boy next door. Thank you.
Let's hear it one more time for McKenna and Elijah. Okay, we are very honored today to have a special guest with us, Dr. Brendon Quinn. Dr. Quinn is here all the way from Australia via LA. He is a 2016 postdoctoral Fulbright scholar. Dr. Quinn is an epidemiologist based with the Burnet Institute Center for Population Health in Melbourne, Australia. He is a public health specialist and continues to expand his knowledge and skills in the area of licit and illicit drug trends, justice, health, and infectious diseases in Australia and internationally via work on multidisciplinary research projects. Based in LA at UCLA, learning about effective treatment approaches for both methamphetamine and HIV. He's here in the US for a year and leaves in June. Tomorrow, Dr. Quinn will be giving a presentation on what works and what doesn't in treating drug-related harms, including addiction. His presentation will be held in Founders Hall in the Noyes Building at 4 p.m., and you're all invited to attend. The title of his remarks today is Getting Lit, Key Licit and Illicit Drug Trends in the United States. And please join me now in welcoming Dr. Brendon Quinn.
Hi everyone. Sorry, I'm still getting set up here. I thought I had a little clip that I could put this in. I'll put it in my pocket. Oh, there it is. I'm really excited to be here today, so thank you for giving me the opportunity to actually be here, and I really appreciate all of you coming to listen to me. I'm not sure if I've ever spoken to this many people before, which is really exciting. But as has been mentioned, sorry, I've got to get used to this little clicker thing. But my name is Brendon, and I'm going to be talking to you today about key licit and illicit drug trends and issues in the United States. So, just so we're all on the same page, by licit I mean legal and illicit I mean illegal. This is what I'm going to be talking about today. Firstly, myself, because I'm really important, but mainly because by talking about my experiences and where I come from, I think it's really important because it underpins some of the themes I'm going to be talking about today, and why I'm here, essentially, and why I do what I do. Also, the main take-home messages of today, of course, drug trends here in the United States, and one specific trend here in Utah that I'm sure many of you are aware of. So, I am from Australia. I'm really sorry if you can't understand some of the things that I say. We will have some questions at the end if you need clarification. Even though I've lived in the States a few times, I still have friends who I've known for years who struggle to understand some of the things that I say. So I am from Melbourne, which is the second largest city in Australia. More specifically, I grew up about 3 hours drive north of there in a little country town called Yarrawonga. So it's actually smaller than Ephraim. No traffic lights, no McDonald's, no Subway, nothing like that. My parents still live up there. It's on the the longest river in Australia, and that's called the Murray River. And it's a lovely spot, so there's a little bit of a geography lesson for you. So I am a drug and alcohol researcher. More specifically, I'm an epidemiologist, and that doesn't mean that I work with skin most of the time, as most people think initially. Think more along the lines of epidemics. The main focus of my research usually is methamphetamine. It was the main subject of my PhD back in 2010 to 2013. But more broadly, I work under the umbrella of public health. And some of those interests or fields that I work on are justice health, so that includes working with people who are in contact with the criminal justice system, be they prisoners or ex-prisoners or professionals working there. International health, mainly in developing countries or third world countries. Bloodborne viruses, mainly hepatitis C virus and HIV. That relates very much to injecting drug use trends because injecting drug use is one of the main modes of transmission of both Hep C and HIV. In LA, at UCLA, I'm learning very much about health issues for men who have sex with men. And I feel very passionately about generating evidence-based practice and policy across all of these issues. And that's sometimes very hard to do because I work in what is considered by many as a controversial field, drugs and sex. And so often the measures that we propose to politicians to try and reduce some of the harms associated with these issues are not politically palatable. For example, at the moment we're seeing a lot of deaths in Australia as a result of bad batches of ecstasy pills, and we're really campaigning for pill testing at music festivals and at nightclubs and in nightclub precincts. It's summer in Australia, so a lot of people are out partying, but it's just not something that law enforcement agencies and the government are considering right now. Sorry, I'm still getting used to this thing. Wait, there we go. So just to give you some examples of some of the projects that I've worked on over the last 2 to 5 years, again, so you know where I'm coming from, I conducted the longest prospective cohort study of methamphetamine use in Australia. In 2010, I recruited about 250 people who were regularly using methamphetamine in Melbourne, and we followed them over 5 years, looking at trends in meth use, other drug use, their health, and importantly, their utilisation of relevant health and social support services and drug treatment. We were looking at treatment barriers and enablers to treatment utilisation. I've done some work overseas. I looked at alcohol and other drug use and gender-based violence among young people in the Solomon Islands over 2015, 2016. And I investigated HIV testing and treatment practices and associated risk behaviours among a few groups of at-risk youth in a city called Bandung in Indonesia. And that they were people who inject drugs, men who have sex with men, female sex workers, and transgender youth. And so we're hoping to improve HIV testing and treatment uptake among those groups and thereby decrease HIV prevalence and incidence. So my main take-home messages for today are, well, one of my main points is that I'm not preaching that drugs are always bad. I'm certainly not advocating substance use, but I'm definitely not demonising anyone who does use alcohol and drugs or who has used alcohol and other drugs. I think that's counterproductive, and I think it's stigmatising, and I think it can be really damaging. I am here to educate you about some of the drug-related harms that exist here in America and worldwide, particularly some of the more severe ones, like death. I'm here to educate you about drug trends in the United States, and I want you to think about how they affect you, how they affect your peers, your families, possibly your communities, and possibly the entire country. And I also want you to think about what can be done about harmful drug use, and I'll give a couple of examples later on. I really want to encourage critical and constructive thinking around drug trends, particularly around relevant media and political coverage. I want you to learn to read between the lines when you read about an article about drugs, because they're not always that accurate and they can be, again, stigmatising, and about how we can appropriately address problematic drug use via evidence-based policy and practice. So why do I do this? Okay, I'm going to give you a little story about my grandma, which is hidden under all these papers that I brought up here. Give me just a second. Here we go. So this isn't very long, I promise. A decade or so ago, I was having dinner with my extended family for my uncle's 50th birthday. My grandmother, his mother, was present, of course. At that point, I had worked in drug and alcohol epidemiology for only maybe a year or two, but I'd spent years volunteering at a non-profit organisation for young people affected by mental health issues and drugs or alcohol, which is something we refer to as dual diagnosis. I can't remember how the topic came up, but my grandmother started criticising people who use drugs. Her key points were that drug users are a drain on society. They don't have a positive impact, they're all bad people with no hopes of redemption, and they should all be incarcerated. Furthermore, taking drugs only leads to bad things. I pointed to the glass of wine in her hand and I said, "But you're drinking a drug right now and nothing bad is happening." "This isn't a drug," she declared. "This is alcohol and it's legal. This isn't going to make myself throw myself through that window over there." And those are the exact words that she said. As someone who, by this point in my life, had experimented fairly thoroughly with alcohol and other drugs and who had a fair understanding of the effects of many types of substance use from both personal and professional perspectives, I realised that she lacked compassion for people who use drugs. She put them all in the one basket and didn't care about their well-being or their futures. She cared about how their lives impacted hers. She demonstrated a remarkable lack of understanding about drug use, including the reasons people use various substances and the types of harms commonly experienced as a result of drug use. For example, I'm sure that more than one person in this world has thrown themselves through a window as a result of alcohol intoxication. The legality of substances was a big issue for her, and I'm constantly surprised how much of an influencing factor it is in how people decide whether a drug is inherently good or bad, and whether people who use those drugs are inherently good or bad. Very frustratingly for me, she lacked a willingness to learn about different perspectives and different experiences. She was perfectly comfortable living in her privileged and ignorant bubble where she could criticise and judge others from afar. I'm reminded of this conversation regularly through with other people and when I read the paper, the newspaper, or articles online. And this motivates me to keep doing what I'm doing. During today's presentation, I want you to remember that for me, people who use alcohol and or other drugs are still people. I've met and interviewed thousands over the last decade, people who use heroin, methamphetamine, alcohol, cannabis, poppers, gasoline, mouthwash, spray paint, nicotine, cocaine, plus countless other substances. People who use drugs are incredibly diverse. Some are bad, just like you have bad people in any population or group of people, but many are very, very good and deserve a second or third or fourth or fifth chance to try and make a life for themselves. And some will end up contributing more to society than the rest of us. You never know what someone's backstory is. One person might be born into a cycle of drug use which really isn't their fault. Another might be college educated and have suffered a horrible accident and now uses illegal morphine because they can't dull their pain through legitimate means. It's important to listen to the facts, and to quote your president, or to quote Kellyanne Conway, what's her name? Anyway, Kellyanne Conway, sorry. We can't create alternative facts around this area. Like other fields, there are people working in the area of drugs and alcohol who have spent decades learning about what works and what doesn't. Whether it's drugs and alcohol or medicine or the environment, you need to listen to the intelligent people, the experts, who care and who know how to change the world in a positive way. So again, why do I do this? To cap that off, licit and illicit drug use, particularly recreational consumption patterns, by which I mean infrequent or sporadic, not heavy or chronic, can result in many positive outcomes. And I'll talk a little bit about those later. But importantly, it can also lead to numerous adverse personal and interpersonal consequences. And that's why I do my job, because I want to reduce and prevent these harms associated with drug use. They might include short and long-term mental and physical health problems, relationship breakdown with partners or family or friends, financial issues, criminogenic harms, by which I mean involvement in criminal behaviours, whether to fund certain lifestyles or because you're intoxicated. Homelessness is a big one, and also death, of course. The latter is particularly evident here in the United States. As you can see from this slide, I hope, I'm not sure if you can see some of those colours up the back, but drug deaths are rising in all 50 states. And this is a huge public health concern. To add some sort of context or perspective to this, the dramatic increase in drug overdoses across the country over the last 2 decades means that drugs now kill more people than cars and guns. So here are the top 10 drugs most frequently involved in fatal drug overdoses in the United States. And these data are from a report that investigated the drugs most frequently involved in fatal overdoses from 2010 through to 2014, and listed here are the numbers from 2014. Note that for this report by the CDC, drugs of interest included pharmaceutical and non-pharmaceutical drugs, including specific drugs and classes of drugs. Just quickly, some of those substances excluded were alcohols, nicotine, food, sorry, I'm trying to think off the top of my head here, gases, and just basically foods that had no industrial or intoxicative effects. So I don't know if any of you can see something in common with those drugs listed in red there. They're all opioids. So about 2/3 of overdose cases involved licit or illicit opioids. Heroin is obviously an illegal drug, but if you misuse pharmaceutical opioids or you purchase them from someone else or take them from someone else, that's classified as illicit also. Regarding these drugs, from 2010 to 2014, the top 10 drugs were the same, but their ranking changed. So for example, cocaine was the second most common drug involved in fatal overdoses in 2014, but hypothetically in 2013 it might have been 7 or 9. The number of drug overdose deaths per year increased about a quarter, from around 38,000 to 47,000. The age-adjusted rate of drug overdose deaths involving heroin more than tripled, the rate of overdose deaths involving methamphetamine more than doubled, and the rate of overdose deaths involving fentanyl, which has received a lot of media attention both here and worldwide, more than doubled in a single year over 2013 to 2014. I should note that relative increases in the death rates involving specific drugs and the rankings of these drugs may be affected by improvements in reporting, real increases in the numbers of death, or both. And unsurprisingly, around half involved more than one drug, which is, again, not unexpected, because polysubstance use, where people use more than one drug at a time, is fairly common. So the bottom line is that in America and worldwide, drug-related deaths are a huge public health issue. Of course, they impact substantially on individuals and families and communities, but they also have considerable impacts on our health, social support and criminal justice systems, meaning that if we can prevent unnecessary overdose deaths, the valuable resources across these sectors would otherwise be used elsewhere. So now I'll talk about some broad drug use trends in the United States, and I'm referring here to findings from the National Survey on Drug Use and Health, or if you want to use that acronym and however you want to say it, NSDUH. So this is an annual survey of the civilian, non-institutionalised population who are aged 12 years and over. Importantly, excludes some subgroups of people, those who are homeless, residents of institutional group quarters such as jails and prisons, nursing homes, etc. And this is an important limitation because it means that the figures presented here are probably underrepresentations of the true extent of drug use across the United States, primarily because some of these subgroups are known to use drugs at higher rates than the general population. So it's a face-to-face household survey. In 2015, they targeted 67,500 people, but they got a few more than that. They were targeting specific quotas of a quarter of the sample who are aged 12 to 17, who were defined as adolescents, another quarter who are 18 to 25, and half who are aged 26 years and over. And they obtained information across various categories of illicit drugs. Regarding alcohol use, as you can see, about 138 million Americans were estimated to have engaged in current alcohol use. And by that I mean they had drunk at least one alcoholic beverage at least once in the previous month. We've got nearly 67 million who are classified as binge alcohol users and 17.3 who are classified as heavy alcohol users. And I should define binge and alcohol for you. Sorry, I've got some text on here that I'm trying to access. Okay, here we go. For men, binge alcohol use is defined as drinking 5 or more drinks on the same occasion on at least one day in the past 30 days. For women, binge drinking is drinking 4 or more drinks on the same occasion on at least one day in the past 30 days. Heavy alcohol use is defined as binge drinking on 5 or more days in the last 30 days. And notably, both binge and heavy alcohol use was more common among those aged 18 to 25, so I'm assuming you guys all fall into that age group, compared to the younger and the older age groups, meaning that prevention, education, and harm reduction measures should probably be targeted mainly towards these groups. So regarding illicit drug use patterns, in 2015, an estimated 27.1 million Americans aged 12 years or older, or about 10% of the country's population in this age group, 1 in 10, were current or past month illicit drug users. And obviously you can see the most common drug there was marijuana. However, an estimated 6.4 million reported using pharmaceuticals in the past month, and that included 3.8 million who had misused prescription pain relievers, and they will generally be the opioids that I listed on that previous slide. Obviously, smaller numbers of people in 2015 were current users of other illicit drugs, as you can see in this figure. I'm not sure, can everyone up the back see that text? Yes? No? I'm assuming everyone's all good. Just to break those figures down by age, again, the people in the 18 to 25-year-old age group were the ones who are most likely to engage in illicit drug use. The same with alcohol. Next, we've got substance use disorders. So the National Drug Household Survey includes questions to classify people as having a substance use disorder in the past 12 months. And these are based on criteria specified in the DSM-4, for those of you who might be doing psychology. And here are the 11 criteria. So you can replace that word substance with whatever drug you're talking about. So that might be alcohol or heroin or marijuana or methamphetamine, etc. So a substance use disorder is defined as the repeated occurrence within a 12-month period of 2 or more of these 11 problems, including withdrawal, giving up important life events to use whatever substance we're talking about, and excessive time spent using that substance. A cluster of 6 or more of the criteria listed here indicate a severe condition. So I hope I haven't made any of you nervous right then. regarding the prevalence of substance use disorders across the United States, in 2015, around 21 million people aged 12 years or older were classified as having a substance use disorder in the past year. And that included nearly 16 million people who had an alcohol use disorder and 7.7 million people who had an illicit drug use disorder. And more than double the number of people with an illicit drug use disorder had an alcohol use disorder. Well, just to look at those figures another way, in 2015, among people aged 12 years and over who had a substance use disorder in the last year, nearly 3/4 had an alcohol use disorder, and around 1 in 3 had an illicit drug use disorder. Importantly, in 2015, an estimated 2.7 million people aged 12 years and over had both an alcohol use disorder and an illicit drug use disorder in the last year. So alcohol use is not my specialty, so I can't tell you exactly what's driving the overall decrease in trend among the younger groups in particular. However, we're seeing similar trends in Australia among high school students and college-age students as well. My friends and colleagues who work in alcohol research have a number of theories for this, and one of the most interesting for me is the rise in use of social media, which for one thing might take time away from drinking, and another might dissuade harmful drinking patterns due to a desire not to look foolish online. Relating to that, you've got young people who really want to look great these days, by which I mean, like 0% body fat, six-pack, that type of thing, and alcohol use doesn't really help with this, as I very well know. Nevertheless, significant numbers of people across all age groups are classified as having an alcohol use disorder, so this means that there's still a lot of work to be done in this area. How are we going for time? What time are we supposed to finish? 1:20, cool. So, with regard to Utah, I'm sure many of you are aware of this issue. Just driving down from Salt Lake City last night, I saw a number of billboards on the side of the highway talking about this exact issue. So, remembering that illicit pain relievers are the second most common type of illegal drug used in the United States behind marijuana, Utah's Division of Substance Abuse and Mental Health has declared the rising incidence of opioid use disorders across the state a public health crisis. Just to clarify, opiates are drugs derived from opium. Opioid is used for the entire family of opiates, including prescribed and illicit, natural, synthetic, and semi-synthetic opiates. It's a bit confusing. The terms have sort of changed over the last few years and with regard to what exactly they mean. Importantly, in the last decade, opioid overdose deaths in Utah increased by 400%. And Utah has the 4th highest rate of overdose deaths in the US. Referring back to the household drug survey data, over 90,000 individuals in Utah who are aged 12 years and over reported non-medical, being illegal use of prescription opioids in the last year. This graph, I hope you guys can see it, demonstrates the ongoing issue of problematic opioid use in Utah. The lines represent the number of treatment admissions across the state according to the patient's drug of choice. So if you attend a treatment service, you can attend there with numerous drugs of concern. For example, I might show up with alcohol, methamphetamine, and cocaine, but generally you have to choose one primary drug of concern. And for the first time ever, opioids, which are the green line, are ranked as the #1 drug of choice reported upon treatment admission at around 29%, followed by methamphetamine at 26.1% and alcohol at 25.8%. So we're seeing a real change here over the last decade. Just so you know, marijuana comes in 4th at around 15%, cocaine and crack are 2%, and all other prescription drugs, not including opiates, are 1%. I should note that I've included those websites down the bottom, and if anyone wants those sources, if you can't see them right now, I've got my email address at the end, and feel free to email me and I'll send you more information. So, on a positive note, the problem of harmful opioid use hasn't gone unnoticed by authorities in Utah across the state, and I am pleased to say that numerous measures have been adopted to try and alleviate the issue. Needle syringe exchange programs, often known as NSPs or SEPs or SSPs, are a valuable harm reduction tool. Aside from distributing sterile needles to prevent bloodborne virus transmission, most offer other prevention materials and services such as overdose prevention, referral to substance use treatment programs, and counselling and testing for HIV and hepatitis C. We have these services that are fairly ubiquitous across Australia, and they have been very effective in preventing a HIV epidemic among people who inject drugs. They're estimated to have saved billions of dollars since the HIV epidemic started in the mid-80s, and we've got a prevalence rate among people who inject drugs of less than 2%, which is terrific. Next we have naloxone, and I saw a billboard along the highway about this as well. It's terrific. It's a life-saving prescription medication used as an antidote to opioid overdose. If you've ever seen an opioid overdose, whether that's heroin or something else, and someone gets injected with naloxone, they wake up straight away. Often if they're a fairly dependent heroin user, they're not particularly happy because you interrupted their high, but they're alive. In the past, it was mainly used in hospitals or by emergency personnel such as ambulance officers. But in 2016, the executive director of the Utah Department of Health signed a statewide standing order allowing pharmacies to dispense naloxone to anyone at increased risk of experiencing or witnessing an opioid overdose, which is terrific. So this has been available in states like New York and California for nearly 2 decades now. Australia only introduced it, I think, if not last year, only the year before, and it's made significant changes and prevented many, many, many deaths. So now anyone can purchase naloxone without a prescription and potentially save someone's life. So if you've got friends or family members or other who might be at risk of an opioid overdose, you can get naloxone from a pharmacy and you can potentially save their life. I also just wanted to touch on the drug treatment options available. You've got AA, which I'm sure you're all aware of, Narcotics Anonymous, which is the version for people who are using other illicit drugs, one-on-one drug counselling, group counselling, home-based outpatient or inpatient withdrawal, residential rehab, and some really cool alternative options that do sometimes work for people. You've got yoga, acupuncture, various sporting options as well. But the point that I want to make is, even though these options are available, there's no silver bullet. So I've got people who've used various types of drugs, whether it be methamphetamine or heroin or alcohol. They might try AA and they hate it, but they try group counselling and it really, really helps them. Same with rehab for meth users. I've got a really good mate who went into 3 months of rehab, was a really severe methamphetamine user before he went in, and now he's living a terrific life and he's just kicking goals. But other people will get kicked out of rehab within 3 days. So I just want to acknowledge that these treatment options exist, but they won't work for everyone. Just to finish off, some examples of current or past illicit drugs being good. I highly recommend watching that YouTube clip if you haven't already. It's from a documentary called Ride with Larry, and it shows how medical marijuana can have a really positive effect for people. So Larry has really severe Parkinson's. He eats edible marijuana and you just watch his muscles relax and his speech slow down, and he just is so happy that he hasn't experienced that for years. There's a lot of ongoing research into looking at LSD and ecstasy for treatments for depression, and there's a lot of randomized controlled trials around the world looking at similar uses for other drugs. And of course, legal methamphetamine is effective in treating ADHD. I've got a lot of clients who are sourcing illegal methamphetamine because it helps treat their ADHD because doctors won't prescribe it to them. There's also still many, many, many avenues to explore. So just to finish off, I want to thank the Fulbright Association for bringing me over to the States. Working in LA for the last 6 months has been an incredible learning experience, and I'm excited about the next 5 months. Of course, everyone at Snow College who's helped with this visiting, especially Cheryl, Celia, and Alex who picked me up from Salt Lake last night, my team at UCLA, and also my team back in Melbourne. Thank you. Sergio.
What do you think about the legalization of marijuana nationwide?
I love it. Sorry, the question was, what do you think about the legalization of marijuana? To provide some context, what do you think about the legalization of marijuana nationwide? I think it would be a terrific idea. I'm not sure if you've heard, but in states like Colorado that have legalized it, they've generated over $1 billion in tax, which can be funneled into education or drug treatment or something positive. In my personal and professional opinion, marijuana is a drug that doesn't really cause that much harm. I mean, people do have to be educated, particularly about the mental health consequences that might be associated with that. But compared to something like alcohol that's legal, I don't think it's anywhere near as harmful. Sorry, this gentleman down here.
In 2002 or 2003, it was decided with our invasion of Afghanistan to not try to wean the Afghan economy off its opium habit,
Mm-hmm.
and they experienced funded drugs thereafter for years. Are we seeing now the effect of that foreign policy decision?
So the question was, we didn't wean the Afghans off opium production, right. And that was in 2002, and now we're still seeing the effects of that. Definitely, there's Afghan heroin being filtered into Australia and America still. So you've really got to be careful when you're using heroin. And there's two different types. Usually you've got the Afghan stuff and you've got the stuff from Asia as well, and they can both affect you in very different ways. So in Australia, we've got some campaigns out there trying to advertise or promote the differences between those drugs, but we really, really have to be careful about that filtering into our drug-using community because they have different harms associated with them.
Do you know why we decided to not?
The US?
Production, yeah.
No, I'm not educated about that, sorry. I can find out for you though, feel free to send me an email. Yeah, look, I don't want to comment on it just because I have a few assumptions about that, but I don't want to, create any controversy. Sorry, we had this lady up here.
There's a Utah-based group called Corn Kills Love, and they recently released a slogan that says, "Fight the new drug," comparing porn use to drug use. Do you think that that's an effective comparison?
So the question was, there's a new group called Porn, what was it, sorry? Porn Kills Love, comparing porn to drugs, and do I think that's an effective comparison? No, I think they're both associated with different types of harm. I mean, I've got friends and colleagues who are researching the effects of too much porn among young people in particular and how that affects their relationships and their sexual behaviours. And I think that's a really different area to using drugs. I mean, I think they both affect different aspects of your life. Sorry, Van.
Does the increase of that antidote, do you think that's going to increase the usage of drugs because people will feel like they can use it more because they have an antidote?
No, not at all. I mean, there's been research conducted both in Australia and here in the US that's shown that there is no significant increase in use of opioids as a result of that. And that's the same with services like needle syringe programs. There's been extensive reviews conducted of that, and just because we're giving out sterile syringes has not at all increased the number of people who are injecting drugs.
Is heroin cheaper right now than prescription?
Here in the United States? Well, it's hard to comment on. I'm always fascinated about the drug economy. I mean, it's a marketable substance, and it really depends on where you are. So if you're in the northeast, you can probably get cheaper heroin than prescription opioids, like black market prescription opioids. But in other areas, it'll be completely different. So it's really hard to answer that question and generalize for the whole country. But again, it's depending on the area, you'll be able to get cheaper heroin. Other places, it'll be more expensive. So in Australia, heroin costs between $300 and $400 a gram. So does meth and cocaine. So, but here they're a lot cheaper. Sorry, go again.
Can you explain the differences? You said like Asian and Afghan heroin are different. So is it difference, like what's the difference in the substance and what's the difference in the effects, like the symptoms and the effects on the body?
So a lot of the time it'll be, the difference will be what they're cut with. Whoever's, you know, obviously there's a lot of steps along the chain, so it'll get produced and then it'll be, you know, produced into opium and then they'll cut it with something and it'll become this powder substance or it'll become a rock substance. And so it might be a different form. So usually it's either powder or rock, which will require different preparation methods. And often, depending on what it's cut with, there's, I can't remember what the substance is, but in the Afghan stuff, they'll cut it with this really basic substance, and a lot of the time people will have to mix it with lemon juice to inject it into their veins. Sorry, I can't see. Oh, over there. Sorry, I can't hear you.
So, is there any evidence showing that prescriptions that have opioid in them are more habit-forming than other prescriptions?
So the question was, is there any evidence that prescription opioids are more habit-forming than other prescription drugs? So you might be talking about stuff like benzodiazepines like Valium and Xanax, or maybe the amphetamine type ones as well. No, I mean, it's, well, the short answer is no. And there's a lot of debate about this, not just with the pharmaceutical substances, but also with the illicit substances. So one of the issues I have, you know, I've already mentioned that my specialty is methamphetamine, and a lot of the time in the media, you get the statement that you use it once and you're hooked, which is really not true. It's very dependent on, you know, different people's biology and psychology and that type of thing. So at the moment we don't have evidence to suggest that, but they're all addictive substances, but you know, some people might be more inclined to that. For example, some people might be more inclined to gambling than others. I'm not a huge gambler, but I've got mates who will spend thousands of dollars in a weekend. So it's the same for drugs. Some people will be more inclined for that and others won't be. And again, it comes down to why you would use it. Some people might be using heroin as to self-medicate depression, for example. But someone who just uses it as a recreational thing or to experiment with it or just to get high is probably less likely to develop dependency.
Do you think legalizing and controlling all drugs by taking them off the black market would reduce deaths and negative effects on society?
So do I think legalizing all drugs will eliminate death and other problems on society? That's a hard one. I mean, I'm in two minds about that. I've seen the really horrible consequences of some drug use, for example, methamphetamine. I worked closely with local law enforcement in Melbourne last year to try and develop an information pack for their new recruits. And I went in there just, again, saying drug users are people, etc. But I can understand why a lot of people are scared of it because, you know, for example, there was one guy who was just, you know, a 20-something gym junkie. So he's this really big, muscly guy, and he used meth one weekend, and he was out of control. And they had to put him in a cell, and he ended up biting his finger off and writing stuff all over his cell wall. And they had to get the, what do you call them, the paramedics to come in there and sedate him with an insane amount of benzodiazepines. But if you look at somewhere like Portugal, which is really the example that people state all the time, they've decriminalised possession of all substances, and that happened over 10 years ago, and they're having terrific results from that. So use hasn't gone up, crime's gone down, and they're not seeing any change in, sorry, they haven't seen an increase in drug-related harms. And again, with legalising marijuana, you can funnel all that money that might otherwise be spent on law enforcement into other positive outcomes. So look, at the moment I am all for legalising substances that I know really don't create that many harms for health services and law enforcement and people generally, like marijuana and probably ecstasy and low-grade cocaine. But I'm still in two minds about stuff like methamphetamine and heroin. Although they do have medical heroin in Sweden for people who are addicted, so you can get a prescription and go in there and get your heroin dose. So I like those sorts of approaches as well. Sorry, that wasn't very exact for you there.
Talk a little bit about dual issues or people that might have mental health issues and substance issues. Roughly what percentage do you think of drug abusers have some sort of a mental health component compared with recreational use?
You wouldn't be able to put an exact percentage on that because it's just so complicated when you've got people who might just use one substance versus 20 substances. But my experience working with methamphetamine users is that it'd be more than 50% would probably have some sort of clinical diagnosis of something, whether that's just anxiety or depression or something more severe like bipolar or schizophrenia. But recreational drug users, generally, I don't think that there would be much more of a prevalence than the general population. And again, by recreational, I mean just, maybe once a month, just completely infrequent and not having those craving aspects of the DSM-4 criteria that I put up there before. We all good? Cool. What happens now?